Hello everyone, today we'll be talking about tracheostomy. So, what is a tracheostomy? So, one thing before we even start, you need to know that these are what called tracheotomy and tracheostomy. So, tracheostomy refers to a permanent or semi permanent tracheocutaneous fistula. However, in practice, tracheotomy and tracheostomy are often used interchangeably. So, what are the functions of a tracheostomy? So, the first function is it provides an alternative pathway for breathing. So what does this do? This circumvents any obstruction in the upper airway from lips to the tracheostome. 2. Improves alveolar ventilation. So how does it do that? In cases of respiratory insufficiency, alveolar ventilation is improved by 1. Decreasing the dead space by 30 to 50%. 2. Reducing the resistance to airflow. Then the third function is it protects the airway. So how does it do that? So by using a cuff tube, tracheobronchial is protected against aspiration from the pharyngeal secretions, blood as in hemorrhage from the pharynx, larynx, or maxillofacial injuries. 4. It permits removal of tracheobronchial secretions. So when does it help with that? This is usually when patient is unable to cough, such as in coma, in head injury patients, respiratory paralysis, or when cough is painful, as in chest injuries or upper abdominal operations. 5. Intermittent positive pressure respiration. If IPPR is required beyond 72 hours, tracheostomy is superior to intubation. 6. To administer anesthesia. So basically, usually we do endotracheal intubation. However, if it's difficult, it's impossible to perform, such as if there's a laryngopharyngeal growth or trismus, then you need to go for tracheostomy. So, what are the indications of tracheostomy? So, one thing you need to know is there are three major indications. The first one is respiratory obstruction, second is retained secretions, third is respiratory insufficiency. So, when we say respiratory obstruction, what are the causes? So, the causes can be infections such as laryngotracheobronchitis, acute epiglottitis, diphtheria. We have got Ludwig's angina, peritonsillar, retropharyngeal or peripharyngeal abscess, tongue abscess. B. Trauma. So, trauma can be due to external injury of larynx and trachea or trauma due to endoscopies, especially in infants and children. 3. Fractures of mandible or maxillofacial injuries. Say neoplasms, such as benign and malignant neoplasm of larynx, pharynx, upper trachea, tongue, and thyroid. The foreign body, such as in the larynx, edema larynx due to steam, irritant fumes, or gases. F. Bilateral abductor paralysis. G. Congenital anomalies. Then the second indication was retained secretions, such as inability to cough, painful cough, or aspiration of pharyngeal secretions. Respiratory insufficiency that may be due to chronic lung conditions such as emphysema, chronic bronchitis, bronchiectasis, atelectasis, or any other conditions in A and B. Then, what are the common indications of a tracheostomy in infants and children? So, in infants below 1 year, mostly it's due to congenital lesions, and in children that are above 1 year, it's mostly inflammatory or traumatic lesions such as acute laryngotracheobronchitis, epiglottitis, diphtheria, laryngeal edema, external laryngeal trauma, prolonged intubation, juvenile laryngeal papillomatosis. So, what are the types of tracheostomy? There's emergency tracheostomy, elective or tranquil tracheostomy, there's permanent tracheostomy, there's permanent dilatational tracheostomy, then there's mini tracheostomy, which is also known as cricothyroidotomy. So, how do we perform a tracheostomy? Open surgical tracheostomy. So, the first thing you need to do is an incision horizontally midway between the sternal notch and the cricoid cartilage. So how do you do that? You look at your finger breadths above the sternal notch. Okay, here. Then this incision is continued down through the skin, subcutaneous tissue, and platysma. Separate the sternohyoid and sternothyroid muscle pairs with a midline vertical dissection. These muscles are pulled away from the midline with retractors, revealing the thyroid isthmus. Isthmus is transected vertically and each side is suture ligated. A cricoid hook, which is placed between the cricoid cartilage and the first tracheal ring, is used to pull the trachea superiorly, while the trachea incision is placed at the level of the second tracheal ring. Then you remove the circular window of cartilage, placement of double lumen tracheostomy tube, then percutaneous dilatational tracheostomy, and frequently used within many ICU settings. Translaryngeal tracheostomy is the most recent technique. So complications of tracheostomy. So they're divided into two. There's immediate, intermediate, and late. Immediate is at the time of the operation. Intermediate is during the first few hours or days of operation. Then late is with prolonged use up to 4 weeks and months. So immediate complications include hemorrhage, apnea, and this follows opening of the trachea in a patient who had prolonged respiratory obstruction. So why this occurs is due to sudden washing out of CO2, which is acting as a respiratory stimulus. So how you treat this is to administer 5% CO2 in oxygen or assisted ventilation. Say pneumothorax due to injury to apical pleura, D injury to recurrent laryngeal nerves, E aspiration of blood, F injury to the esophagus. This can occur with tip of knife while incising the trachea and may result in tracheoesophageal fistula. 2. Intermediate complications. So this occurs during the first few hours or days. So bleeding which may be reactionary or secondary. Displacement of tube, blocking of tube, subcutaneous emphysema, tracheitis and tracheobronchitis with crusting in trachea, F. atelectasis and lung abscess, J. local wound infection and granulations. Then when we talk about the late complication, this usually arises with prolonged use of tube for weeks and months. So the first complication is hemorrhage, which may arise due to erosion of major vessels, B. laryngeal stenosis, which may be due to perichondritis of cricoid cartilage, C. tracheal stenosis, that may be due to tracheal ulceration and infection, D. tracheoesophageal fistula, which may arise due to prolonged use of curved tube or erosion of trachea by the tube of tracheostomy tube. E. Problems of decannulation, which is commonly seen in infants and children. Persistent tracheocutaneous fistula, then you can get problems of the tracheostomy scar. You may get a keloid or unsightly scar. Then you may have corrosion of tracheostomy tube and aspiration of its fragments into the tracheobronchial tree. So basically this is a summary of the complications. So that's all about tracheostomy. If you like the video, please like, subscribe. Thank you.